Look, I'm supposed to now introduce Dr. Miriam Duggan. I think she has been introduced so eloquently by Father Michael that there is not much I can say, except to say that we are hugely admiring and in her debt for her work in Uganda since the 1980s, where she founded the Youth Alive programme, which provides education around sexual behaviour, drugs, self-esteem and constructive life choices for young people. It has great success in Uganda, and it has been extended across 21 African countries. She has been back in Ireland, and she is now working with Hands of Care and Hope in Nairobi, which supports those living in poverty and women living with HIV. And she recently brought our new ambassador around some of the slums of Nairobi to show him what life is really like in Nairobi. Not that he didn't know it already, because Vinnie O'Neill, our ambassador there, is one of the great champions of our work on HIV and AIDS. So as we know, Sister Miriam has been recognised just last weekend, and it's probably one of the main reasons, apart from this, that she's home in Ireland, was to receive the Presidential Distinguished Services Award for the Irish Abroad from President Higgins. It is richly deserved, and it is also an award bestowed by the President on Father Michael Kelly. And it is an award that is particularly important, I think, in recognition of the work of Irish religious and Irish missionaries around the world. And I think we should, on this occasion, take a minute or two just to recognise that. I see the Chief Executive of Mission Cara in the audience, Heidi, up there. And I see many of the Irish religious sitting here for this occasion. And I think there's been a lot of praise tonight for Irish Aid. But what is Irish Aid? It is the Irish People's Aid Programme. And why is Irish Aid? It is because the Irish people learned enough to know that they had an obligation to have a development programme. And a huge part in that was the work of Irish missionaries. For many of us, probably the first we ever learnt about Africa was when missionaries wrote letters or visited schools and told us about Africa. And for many people who volunteered to work in Africa and the developing world, it was because of the inspiration of our missionaries, of the work of our missionaries. And when we visit Africa, we meet them everywhere. And when we meet African leaders, we hear about them because they taught them. So it is a matter of huge pride for us that Ireland is still represented in Africa and abroad so brilliantly and so effectively by Irish religious, Irish women and men who have given their lives to fighting poverty and hunger and disease. So I just want to say that from all of us that sometimes it's not said and sometimes it's not understood. We are inspired still by you, and we appreciate and value your work, and it has been recognised so clearly, I think, by the President, and will continue to be. So thank you for your work.
I sat there thinking, who am I to follow Professor Sheila and the Minister, and who am I to stand in the footsteps of Father Professor Kelly, an SJ, as a poor Franciscan. But I'm going to speak from my own experience, not from a profession, but from my own experience of working on the ground in AIDS prevention. And I think it's a very important. The photograph I've up there is one of my favourite photographs. It was taken outside a clinic. The 7-year-old, as you can see, has very advanced AIDS, holding his 1.5-year-old brother. Their mother had just died of AIDS. But it's a photograph that over the years has inspired me to keep working. And I think the theme that we have, keeping HIV/AIDS on the agenda, is a very important one, that we keep AIDS going. Today we are hearing of some rising prevalence rates or stagnation of the level. We had hoped that the level would fall much more, but there's been in many areas stagnation. With the introduction of ARVs, many people, and I would hear this on the ground, feel, well, if I do get AIDS, there's treatment there. and I won't have to die. We're not seeing the same deaths as we used to see in the early 90s, and therefore there isn't that same fear element there. And so in a sense, many people have become complacent. It's great that we have the ARVs, but they shouldn't allow to complacency. My lecture is based mainly on my experience of that journey in AIDS prevention over the years. When the AIDS epidemic first broke in Uganda, it was just at the end of, I think, our third coup at the time, and we got an ELISA machine. It was great excitement, but what we didn't realize that already we had 13% of women attending the antenatal clinic who were positive. And very quickly after that, we were seeing very great numbers of people coming to the hospital. So much so that we couldn't cope with the numbers, and we set up a home-based care program to care for them. And it was during one of the visits out to the homes that I really saw the devastation that AIDS was bringing into families, into homes, the consequences of somebody, especially if it was the breadwinner, getting, and people being thrown out because they didn't have their rent, and people not having food because they didn't. So it was that, and I remember sitting on the bedside of a young man one day, and he was dying of AIDS, and pouring out his soul of regret and disappointment and everything else, and realizing, gosh, AIDS is preventable. We young people shouldn't have to suffer like this. We must do something to try and prevent this suffering, this great tragedy that's upon us. And it was then that I started getting involved, if you like, in prevention. Up to that, it was mainly care, but it was then that it was that young man, watching him die there, that really inspired me to get involved in doing something about prevention. And shortly after that, in 1991, I was invited to Dakar in West Africa. There was a conference organized by CAFOD, the Caritas of Britain, and which brought together about 50 of us from different Christian denominations to know what was the answer to the spread of AIDS. That was the theme that we, and we spent 3 days on the coastline of West Africa, one of the most furthest points, just discussing and debating what was the answer to the AIDS pandemic and what could we do to prevent it. And we came up with a statement of belief, and we felt very proud of this statement. It was back and forth and all the rest, but it says a lot. It says, we believe that individuals and whole communities have the inherent capacity to change attitudes and behaviours. The power to fulfill this capacity is often denied or is not exercised. This power must now be recognised, called forth and supported from both within and without. This will enable people to initiate and sustain behaviours that promote a healthy state of mind, body, spirit and environment. A critical component in the process is a supportive response to those living with HIV in the community. We recognise that behaviour change at individual and community level in the present HIV pandemic is a complex and ongoing process. It is inextricably linked to such basic human values as care, love, faith, family and friendship, respect for people and cultures, solidarity and support. The present pandemic affects everyone. Our experience as affected and infected individuals proves that behaviour change is possible. We believe that behaviour change is the most essential strategy in overcoming the HIV pandemic. And we went into the big conference with this. We spent the night writing it out on big posters and went into the big conference with it. But we weren't received very well. There were other things on the agenda. At that time, there were all sorts of messages saying that young people could not change, that culture could not change, and therefore needed to be given the condom, instead of encouraging them to turn away from the high-risk behaviours. At that meeting, it was felt that we should tell people that they can live behaviors that promote a healthy state of mind, body and spirit and environment. Our behaviors are very much linked with the values and attitudes we uphold. Probably the most important line in that statement is the last one. We believe that behavior change is the most essential strategy in overcoming the AIDS pandemic. At that time, it was realized that more and more information was being given, more and more statistics were being published, but the virus was continuing to spread. Nothing was changing except that the numbers were increasing. It was realized that information and awareness were only the first step that had to be taken. There was a need to look at the root causes for the spread of the disease. What were the underlying behaviors and attitudes that were leading to the spread? What were the good values that society was ignoring? At what places were the risks high? What was the fertile ground that HIV had found? And these were, we looked at what were the root causes that we really needed to address. In any infectious disease, prevention is key. And to inform people about the disease and the way it is spread is important, but it's only the first step. We need to go deeper. We needed to look at the root causes as to why the virus was spreading and to address them. Sister Kay Lawler, who is a medical mission sister, was at that, from Kitova Hospital in Uganda, was at that meeting in Dakar with me. And when she came back, she put together a program called Education for Life, a Behavior Change Process, based on the helping skill model of Jared Egan, which is a behavioral and problem-solving approach. It is designed to facilitate a person's movement through the various stages involved in changing behavior. And this just gives you a summary of the thing. It is mainly in 3 stages. The first stage is knowing and accepting the present reality. What's happening on the ground? Why is the AIDS spreading? And then focusing in on different areas and looking at what has been overlooked. And then the second stage is choose and commit yourself to a possible new behavior, what needed to change, and then the action stage. Participants going through the process are challenged to make responsible, informed, and life-giving choices. The key is to help participants to discover where they're putting their health at risk and what behaviors they need to change. Guided questions are given at each subsection depending upon the age of the participant. These are discussed in small groups, and you can see we often worked under the trees, and answers presented at the plenary where further discussion was facilitated. Role plays are used to answer some of the questions. As you know, in Africa, they love to have dramas and they bring out great messages. And if you want to get answers that people can't verbalize, give them to do it in a role play and you'll get the answers. And then they presented it back to and for the further discussion example. For example, in stage 1, questions around relationships, what happens at nightclubs, disco halls, rave concerts were discussed. Questions related to drugs, alcohol, and their role in the spread of HIV. It is well recognized that in places where there is an abuse of alcohol, people are out of control and the prevalence rate of HIV are higher. The root cause may be the alcohol abuse or the taking of drugs. What were the cultures that were promoting the further spread of HIV, and what could be changed? Questions around freedom and the often false concept of freedom are discussed, helping people to see that the only true freedom is the freedom to make responsible choices and to be accountable for the consequences of one's choices. Safer sex, safe sex, and the many issues around condoms were openly discussed, helping people to understand that the only true safe sex is sex with a lifelong, faithful partner. Participants are helped to understand the difference between the condom will prevent and the condom will reduce the risk, realizing that the risk is high when we are speaking about a disease for which we have no cure. Failure rates are not just percentages, they are about people's lives. Unfortunately, due to the crisis situation that many countries faced, everyone was looking for a quick solution, and the condom was often promoted as the answer, without looking at other areas. The basic belief is I need to change, I have the capacity to change, and I can call on the spiritual power to help me to change. As a doctor and gynecologist, I never cease to be amazed at the way condoms are promoted to the youth as the answer to AIDS, when we know the failure rates in preventing pregnancy, know the breakage rates, know often they are not affordable, and when people are under the influence of drugs and alcohol are rarely used. It is interesting to note that in the USA Congress, after years of promoting the condom to prevent teenage pregnancy, they invested a large $230 million to promote behavior change to try and reduce the early pregnancies. Yes, condoms will reduce the risk, but risk reduction is not enough. What we require is prevention, true prevention. In stage 2 of the process, alternative behaviors and values are discussed. It is important to look at alternatives, as one of the reasons people fail to change is because they fail to look at an alternative. These new values and behaviors are then critiqued as to how possible it is to live them today, how to overcome the negative peer pressures, how to make responsible choices that will help a person become the person they want to be. What are the values one wants in their life? Participants are helped to commit themselves to sustaining a good behavior or to change from an at-risk behavior to a new life-giving behavior. The third stage is devoted to planning as to how to put into action the new desired behavior, and also a group may plan on how they will support each other in their desired behavior. In this process, the participants come up with the new behaviors and values that they want. All the facilitators do is to give the guided questions and facilitate the dialogue. One does not go into a group and tell them where they need to change. You help them to discover what they need to change, or where they're putting their life or their health at risk. In order to heighten the dynamic of the process, a few short inputs are given on the gifts of sexuality, the gift of procreation, the current statistics on AIDS, and how values influence attitudes and behaviors. Various skits, songs, times of reflection, liturgies are used by the facilitators to enrich the program. While working with this process, it was realized that groups making the most consistent and effective use of the process have recognized and incorporated an element necessary for bringing about a sustainable change. That is the element of faith. Using the power of prayer, the Word of God, times of reflection brought a depth into the program. And this is for every religion. And often when you are working with a group where there were mixed religions, it was a great dynamic because people shared what their religion asked of them in these situations. And just as in Alcoholics Anonymous, where people are helped to turn to God to make the change that they need to change, or the behavior that they need to change, so in our work with the AIDS situation, we did the same. I've been amazed how during inbuilt times of prayer and reflection, participants in the program have been challenged and touched deeply, and in God's grace have been able to make a commitment to a new way of life. And I'm not just talking about youth in school, but I'm talking about working with prostitutes, working with people from the street, working with adults, and all sorts of groups. We all need that God presence in our life. I'm going into it again. Thank you. In a review from UNAIDS by Hurst and Chen, there are no definite examples yet of generalized epidemics that have been turned back by prevention programs based primarily on condom promotion. We need to look at the other aspects in order to bring about the necessary change and to bring about the desired what we need. The program can be carried out in various ways, either doing it in a block period of 3 to 5 days or doing it on a weekly basis. While the program started in Uganda, it quickly spread to different African countries. People came to Uganda for training, and at times teams went from Uganda to other countries to bring the program. People were eagerly looking for answers on how to prevent the further spread of AIDS. We trained leaders of different religions in this program, where they used their belief to strengthen and support the process. Working with a group, Then, having done this program with several groups, young people started coming back and started saying, we need more support, we need more help. And thus we started what we call Youth Alive. Just through this process, people are helped to discover what needs to change in their lives, take the necessary steps to bring about that change, to make responsible choices, to know there is a spiritual power that can help them sustain a good behavior or change, and to know that they can be witnesses for change and save lives. The Youth Alive are positive peer groups where young people who've gone through the program meet together, have further input, or could you like workshops on character formation and different things, but also do a lot of other activities together. The challenge is to turn negative peer pressure into positive peer pressure. The groups are now very active in schools, in parishes, in colleges, universities, and in several African countries. And while they are based on Christian faith and values, they welcome youth from every other denomination or faith. The specific objectives are to educate youth regarding HIV/AIDS, to help them grow an awareness of correct spiritual, moral and cultural values, and to encourage and assist youth to develop their talents and avoid idleness, to address poverty and to develop a healthy state of mind, body, spirit and environment through ongoing character formation. And this is where we use a lot of music, we use a lot of songs composed to bring the message to others. This was street drama, which was very, very effective in many places, particularly in the rural areas. And this is where you had youth to youth bringing the message to other youth. And in order to encourage the young people who were not sick, to reach out and help those who were suffering from AIDS, they were encouraged to have fundraising drives, and this was an occasion in Uganda where, in Kampala is built on 7 hills, but they pushed beds from the 7 hills, one with a patient on it, not a real patient, but a student, and they collected money on the way. And then this was in the city square where they presented the minister with money to help AIDS clinics. But it's just to keep that alive and to keep them helping others, not to turn against people with HIV/AIDS or to feel any way better than them, but to really reach out and help them. Quickly, the program spread to many, and then the logo changed to Youth Alive Africa. The country that first focused on the behavior change process was Uganda, and it had a very big effect there. As you know, one time Kampala was known as the AIDS capital of the world, but the prevalence very quickly fell from 27% down to 6%, and particularly among the youth down to 2.7%. Sadly, at the moment, I hear it is beginning to creep up a bit again. And maybe we need to. As the programs developed over the years, many new programs were added on as needs arose. And these, this just shows you in Zimbabwe, where there's a very active Youth Alive program as well. In Kenya in 1993, the program was started, and in Tanzania. And in an evaluation done in Kenya by Pressme's Africa showed that 78% of the youth who had gone through the program had changed sexual behavior, 12% had stopped indulging in alcohol, and there was a greater positive self-image among youth who had done the program. Young women were more assertive on their right to say no to sex. And there are more positive attitudes towards people living with HIV and AIDS. In Zambia, where the program was started in 1998, most youth who had gone through the program indicated that they were abstaining from sex and refraining from drug abuse, stated that abstaining from sex was not only best but was possible, and that the program had made a meaningful impact on their lives. In all countries, the AIDS prevention gained momentum, so were new programs introduced. Examples were support groups for married couples, and particularly young married couples who are often struggling in life, but to bring them together so that you can really have that aspect of faithfulness within the marriage. Character formation programs, training of satellite teams of facilitators to go into many of the rural areas, and support groups for youth living with HIV, and economic empowerment, especially for a lot of women. I've just taken these figures from the recent report out from resources out from Kenya of 1914, but it still shows you, as already been emphasized today, the large number of people who are still living with HIV/AIDS, and even the increasing figures. And in this graph, it shows you from 2003, which is the dark blue, then the orange is the 2007, 2008 is the grey colour, and then 2012 is the blue colour. But one thing I'd like you to look at is, particularly there in the men, since 2008, there's been no drop. Despite all that's been done, there seems to be a stagnation going on there. There's been some drop among the women, in the women, but it's still too high at 6.9%, while in the men it's 4.2%. What is the cause of that stagnation? Why can't we get those figures lower? And I think that is part of the challenge today as we try to move towards zero effect. And now this graph shows you the percentage of women and men aged 15 to 49 who have had sexual intercourse with more than one partner in the past 12 months. And it shows you in 2003, it was 11.6% among men and 1.7% among women. And then there was a dip down to 9.3 in 2009, and a dip in the women down to 1.2. But then when you come to 2012, you see a very big rise up to 14.7%, right? And yet an emphasis has been put on partner reduction. What is happening? What is the message that's not been received? What is making men more promiscuous? Is it because now they're circumcised? Is it because we have ARVs? What is it that's making it that jump? And these are the areas that we need to really look at and see what can we do. This is another graph taken from that report, which shows you intravenous drug abusers have still got an 18.3% prevalence rate. Men having sex with men, 18.2%, but the number isn't very high. Sex workers, 29.3% prevalence rate. That's dangerous. And what can we do? These are the gap areas that we really need to begin to look at and to see what can we do to address them. Otherwise we will stay stagnant or we will start rising again. And I think these graphs show that there are so many areas that we still need to tackle. For mother-to-child transmission, in Kenya there's over 70.60% coverage, but that leaves 30% of babies that are not covered. And as we see, there's been increasing, while the overall number has fallen, there are still new cases every year. So how can we make sure that every woman that is HIV positive has prophylaxis coverage during her pregnancy to prevent that further transmission? And are we just going to say that 30% is acceptable? Presently, I'm working in a large slum area in Nairobi, and it's opened my eyes to another part of the journey in prevention. Because when you really work with the real poor, you see another side of things, and you can see why the AIDS is spreading in places like that. Unemployment is as high as 60% among the youth. 64% of the children attending the 3 schools that our sisters run for the poor are either orphans or from households of single mothers. Young women sell themselves in sex in order to survive. Crime is high, drugs and alcohol abuse abound. The environment is very harsh. Now, I've often looked around and said, if I had to go home to a little tin house with a mud floor and a leaking roof and maybe 2 or 3 kids crying in a 10 by 6 room, I think I'd end up down at the pub as well. When you look at the harshness of the reality of the conditions in which many people live, and they don't know where the next meal is and often go to bed hungry, can you blame them? You know? My work is to help in rehabilitation, motivation and behaviour change and character formation for dropout of schools and young people who've been idle for many years just hanging around, because idleness again leads to a lot of the promiscuity. In these cases, the alternative is to change their mentality, to help them believe that things can be different, to get them into skilled training and employment and out of chronic poverty. If we don't get people out of chronic poverty, I think we will still have large pockets of places where HIV is spreading. After they have attended, we run a 3-month program with them in groups of 50. We help to get them sponsorship into skilled training, and when they have a skill, they have a much better chance of employment. And I suppose one of my great joys is seeing some of these people who've been idle for years, who just felt hopeless and were in crime. Some of my best friends these days are gangsters, or were gangsters in the past, but they've now straightened their life out and they're holding down a job and they feel so proud. And they come and tell you, you know, I'm so happy. And I think that's what we need to try and do, to get them employment, to get them the training they need, to get them employment, and to get them out of that chronic state of poverty. At the moment, many of them have finished their training and several have got jobs. We have 87 still in training and another whole group waiting to start in January. And the lessons I've learned in that poverty needs to be addressed in the prevention of further spread of HIV. People need to be given hope and a reason for living. Idleness needs to be counteracted by employment. The alternative that poor people need to be given is a way out of poverty and a belief that life can be fulfilled. Addictive behaviours need to be addressed by motivation and self-belief. HIV/AIDS prevention has so many ramifications. It is part of a very big picture, but foremost is poverty, addictive behaviours, disrespect for women and the ability of people to be able to make responsible choices. Another important line in the statement of belief is a critical component of a supportive response for those living with HIV and AIDS in the community. It's very important that those people with the virus are not rejected or isolated. I work with 2 groups of women who are living with HIV AIDS, and they're wonderful women. They're doing all sorts of crafts and doing all sorts of work, and they're a very, very happy group. But it is because they're accepted within the community. I think in Uganda we were blessed in that we had Phil Lutaya, who was that famous singer who had AIDS and came out very early in the epidemic there, and with his songs and everything, and he said, come out and be together and help it, but don't pass it on. And I really want to salute those people who have openly spoken about their having the virus and have helped others, because people will listen to others and who have shared with them the risk they took and helped them to avoid those risks themselves. Having worked in several African countries and witnessed many lives changing, I'm convinced that there is a great challenge to promote a culture of life through helping people to look at values and behaviours that need to change, not only to prevent AIDS, but also to improve the quality of their lives, and together to address the root causes of the continued spread of the virus. And what is the way forward? And this is just my own, to address the poverty issues that make people so vulnerable. We need to do that. We heard Father Michael speak about people being hungry, people not able to take their ARVs, and that I have experienced the very same thing. And even where they sell their ARVs in order to be able to get food. To address the addictive behaviours that are, whether it is drugs or alcohol, that are making people, again, more susceptible to getting the virus. To address the multiple partners. That can we, at one stage we were saying that multiple partners were spreading the HIV/AIDS, but I think we need to address it again and to further reduce the mother-to-child transmission. And that means we need to step up the prophylaxis for women who are HIV positive. Yes, statistics would seem to point to stagnation and in some areas to rising levels. Maybe we too need to believe that it is possible to reduce the prevalence rates further, especially if we have the courage to think outside the box and address more vigorously the root causes. Thank you.